In this patient, you think the contracture, well, this patient is already operated one. So this is, you said that this patient has a range of movement from 45 degree to 110, which is absolutely pain-free. There is no more passive give way of the movement.
It doesn't look very a hard endpoint on.
Okay.
There's some passive, I would say.
Okay. Okay, so there's still a give way at the end.
Yes.
All right. All right. And when you stretch it from 45 degree to further extension?
Doesn't look like a hard endpoint.
It gives you a little way. All right. All right. Why is it important to know all this?
So it tells you whether the pathology is intra-articular and or extra-articular, so you can plan your treatment accordingly.
Okay, okay, okay. All right. You can, yeah, you sure you can treat your patients accordingly. So let's say if it is absolutely a you are suspecting a extrinsic type of a stiff elbow, where you find there's been a soft tissue injury and you find there's a soft tissue contracture. The patient comes to you, let's say in the 3 months of that injury, and let's take a hypothetical situation with you. Patient comes to you with the injury, soft tissue injury, where he's been immobilized, and he's been asked to do active exercises maybe after 2 or 3 weeks, and then he lands up with a stiff elbow in, say, let's say 3 to 4 weeks time with you. What will be your approach in this patient where the movement are from 45 to 110 degree at that time?
So I'll just first investigate to see after my examination, get an X-ray at least done to rule out any ectopic ossification and all.
Do you think at 3 weeks of injury, 3 to 4 weeks? So what will you find clinically at that time if you are suspecting, let's say you are suspecting a myositis?
So I'll
what will you find?
Some hard mass, if I'm a bony mass in the...
Let us say when you are palpating the elbow,
Yes.
when you palpate your elbow, then 3 to 4 weeks time, and patient has enough immobilization, and you are asking a patient to do active movements, but his movements are about 45 to 110 at that time. You palpate, what do you find? And you are suspecting myositis, let's say. You are suspecting myositis.
So that at that time it would be just a developing initial stage.
Yeah.
So that maybe some thickening of the...
it will show you signs of inflammation. It will show you signs. So what signs will you find when you are palpating the elbow?
The temperature may be raised.
Right.
Some inflammation, redness may be there.
Yeah, may or may not be there. Yes.
So, because that is the acute phase of myositis then.
So, acute phase, your patient comes to you and you find there's an acute phase. Acute phase, you find that the local temperature is raised and you can feel some, let's say, a dewy swelling. You can find that there's fullness in the cubital fossa and the patient resists the movement. It's painful to him. So patient movements are painful, and local examination you find that there is a dewy feeling, there is a local tenderness, and temperature is raised. So what will you do?
If in an acute phase of myositis, I'll give it some rest and not mobilize it.
Okay. So with rest, would you like to give him some medication as well?
Maybe some anti-inflammatory, maybe like...
which anti-inflammatory do you specifically like to give in these patients? Indomethacin. Why indomethacin?
So I'm not sure.
Well, you see, indomethacin has a definite, anti-osteogenic potential. So this is the one which inhibits bone formation. It's one of very potent anti-inflammatory. which inhibits bone formation. So you want to take advantage of that. What's the usual dose that you give?
75 milligram per day.
All right. So 3 doses, 25 milligram 3 times a day. Yes. How long would you like to give it?
At least for initial 3 to 6 weeks.
3 to 4 weeks. Yeah. Yeah. You can 3 to 4 weeks good enough to give this drug. And then you find, let's say you examine him and you find in 2 weeks time or 3 weeks time it subsides. So this acute inflammatory phase goes on for 2 to 3 weeks.
2 to 3 weeks.
And then should you be mobilizing the elbow at that time?
In the acute phase?
Yeah, moment the acute phase is over.
We start in pain-free range, not to make it painful, but in the pain-free range we can start mobilizing slowly.
Right, so good. So how do you know that this myositis has matured?
So again, the local signs of temperature increase.
So now you say that this patient possibly had 2 surgeries done, and now he has got 45 to 110 degree. He's come to you. What will you do for him?
So his complaint is mainly a extension loss problem. Flexion is quite good. He's able to do most of his activities of daily living with his elbow movements. So I'll keep him on a conservative treatment. We can give him a steroid injection into the anterior capsule, and then after that we can put him on a stretching program, exercises, and we may even use a turnbuckle splint. But we'll tell him that since it's already 3 years since the injury, and he's already undergone 2 surgeries, so it is a trial, and it may or may not improve.
Okay. Let's say the patient asks you that how many steroid instillation will you do for me?
I'll give a single installation only.
Okay, why not more than that? More than 2 or 3?
A single dose, I think, if there is no pain with the patient. We're just trying to see if there's some inflammation inside the joint which may be blocking his range of motion.
Okay. So you want to instill the steroid right in the anterior capsule, so that if there is any inflammation around, that could be taken care of, because it's already 3 years old affair. If you give repeated injections, then the loss of proprioception in the joint, which could be very disabling to the patient and can lead to a neuropathic joint later on. Even young man, you give a repeated injections, you find that there is a snapping of the tendons. So that is what you are scared of, that no repeated injections to be given. You are absolutely right that you want to give a single dose just to subside if there is any inflammation and benefit the patient, even if he can get 10 or 15 degree of further extension. So because you are aiming at, what is your aim?
To gain some extension.
Because at 30 degree of extension, he'll be satisfied.
Yes.
So if you can 45, if you can get 10 degree, 10 to 15 degrees, he'll be so happy. So your purpose is not to give more than 1 steroid instillation in an elbow. Right. Fair enough. So in such situation, would you attempt to do another release in this patient? Another, say, lateral column has been done. Can you do a medial column in this?
Theoretically, yes, but I think it's 3 years, 2 surgeries. Any more surgery may lead to maybe a painful elbow, it's pain free at this moment. It may become painful and may even lead to more scarring. So I don't think so surgery would be advisable at this stage because of the history of the duration and the number of surgeries already done.
I think you are absolutely right that you will not attempt to do any more surgery on this patient because surgery can worsen him. There's more scarring, more surgical insult to the elbow. Elbow is a very sensitive joint. It's an extremely sensitive joint. Of all the joint in the human body, elbow is the most sensitive joint. And you see, you said that this patient had a, soft tissue component, right? This patient had soft tissue injury. Of course, he might have had a posterior dislocation as well to start with. So the repeated surgery can give further insult to your patient. So in elbow, you should not be doing repeated surgeries. And one should be very careful because repeated surgery can also result in myositis ossificans or heterotrophic ossification. Where does the myositis ossificans normally take place in the elbow?
Usually in the muscle, the brachialis.
Brachialis. Okay. All right. Fair enough. Thank you.
Thank you, sir.
Could you demonstrate the arc of motion in your patient?
Yes, sir.
On their elbow?
So I'll ask the patient to keep his arm on the table. Then I'll ask the patient to extend it. सीधा जितना जाता है उतना करके दिखाओ. So this is going up till here. This is about